Pandemic era, it has now become very easy to perform and interpret as well. So as I mentioned, there are two exons primarily, exon 2 and exon 3, in which mutations holds a clinical relevance for AS identification. So whether it is only exon 2 identification or it's identification of mutations in exon 2 plus 3 that holds a significant clinical relevance. So in this particular study, it was concluded that screening with both exon 2 and exon 3 through HLA-B27 testing by real-time PCR provided more than 99.9% sensitivity, and which was found to be more sensitive as compared to the single exon assay identification, which is exon 2. So in this all discussion, what we could identify was that HLA-B27 positivity along with two other SPA features as identified, as classified in AS classification criteria, holds an important clinical perspective for us to identify and to correlate the incidence of AS in those patients presenting a lower back pain for more than 3 months and in their mid-30s or mid-40s. Also, this testing with real-time PCR offers a higher sensitivity, higher specificity, specimen versatility is very important in this case, and the throughput can be very high. Also, through real-time PCR, we may end up getting detailed genetic information also about these mutations. And as I correlated that detection with exon 2 and exon 3, it enhances the confidence in reporting with detailed identification and coverage of across all the alleles and their subtypes which may get mutated for this development of AS. So for the MedSource Biomedicals, since we had to play a T20 match of just 10 minutes over here, so for detailed discussions and exchanging the thoughts about this detection for HLA-B27 and the clinical perspective of ankylosing spondylitis, we can discuss further over the stall number 18. Besides that, we will be presenting a hands-on experience for all of you for the fluorescence microscopy for the ANA IFA study. Thank you so much.
Thank you.
And one thing I would like to mention that we at MedSource Biomedical strongly believe that accurate diagnosis is the grammar for the definite accurate prognosis. Thank you so much.
Thank you so much.
Thank you, Dr. Sharma. May I now invite on stage Dr. Sushrut Sen for his perspective on the biochemist perspective of autoimmune disease, which is very important. Again, he needs no introduction.
Already you have deducted 3 minutes time from my session. Fair enough. So you have to apply Duckworth Lewis. Please don't start now. So the today's topic is blood markers of autoimmunity. It's a huge topic actually, impossible to cover in 20 minutes. So I had made it cut short with the term common. So otherwise it's not possible to finish up. And whenever we talk about autoimmunity, we actually say that et tu brute, that our own person is actually harming us. It's very difficult to digest, but it is the fact. So you may call it Brutus, you may call it Trojan horse, but our body needs to fight with this autoimmunity. So autoimmune diseases, the possible causes and risk factors, I'm going to just hurried up all these things. These are age, now Western diet, gender, environment, hygiene, and genetics. They play a most part of development of autoimmunity, emergent of autoimmunity. Of course, these are the pathogenesis, where you may have some cross-reacting antigens, some neoantigen formation with the help of physical agents and drugs and others. Sometimes may have a molecular mimicry. So our own antigen may have a mimicry with a foreign antigen, and therefore the antibody acts on that, so that develops an autoimmunity. There are certain antigens in our body, particularly the lens, the testes, they are never exposed to our blood, so they are sequestrated antigen. By chance they are exposed to blood, they may develop an autoantibody. And also sometimes the polyclonal B cell activation, which may be because of chemicals, antibiotics and so on, and sometimes the super antigen activation. Now how strong is the defense of ours? That is we have to see. So we have two kind of defense, the central tolerance and peripheral tolerance. So now you talk about central tolerance, as you know, whenever there is an immature lymphocyte, the antigen producing cell, the APCs come to the lymphocyte. If it reacts with that antigen, then it is a negative selection. It will not be matured further. Those who does not react will be matured. So the first defense is the central defense, when during formation, our body tries to cut off all these brutus. Now, these are all other peripheral tolerance, which may develop after autoreactive T cell after maturity. Sometimes there is an activation of the suppressive T cell regulatory cells. Sometimes absence of energy, immunological barriers, particularly for sequestrated antigen, and sometimes these autoantibodies are very low in concentration, so they don't evoke any response. Now I'll have a broad classification of this, because on this broad classification I would like to carry on. It may be an organ specific or system specific. So if we call it organ specific, there are the common things are in our clinical cases are myasthenia gravis, Addison's, autoimmune hemolytic anemia, good posture syndrome, Graves' disease, Hashimoto's thyroiditis, ITP and IDDM. These are very common things which we encounter day-to-day practice. And for systemic, we actually encounter very frequently SLE, Angst-Pond, multiple sclerosis, rheumatoid arthritis, scleroderma, and Sjogren's syndrome. So I'm giving only those who are very clinically commonly found. So the diagnostic modalities we use are indirect immunofluorescence, IFA, competitive or indirect ELISA, maybe ECLIA, and lastly the immunoblot technologies. These are all the technologies which can detect these autoantibodies, sometimes the antigens as well. So this is actually, when I'm talking about it, is like a maze, huge number of autoimmune diseases, and they are markers, so you have to find the maze and help the clinicians to get the right diagnosis and right treatment. So therefore, our role is actually how to meander through the maze. The common and predictable offenders which I would like to talk with is the anti-CCP, ANA, anti-dsDNA, anti-SRP, ANCA, and anti-TPO, anti-TG. These are anti-thyroid antibodies. So these are very commonly we encounter in our day-to-day practice. I am again saying that's commonly because this autoimmunity is a huge one. I cannot cover and I cannot address each and every one. So let's start on this, a biochemist on vigil, where I, or as a biochemistry department, where you can have a contribution. So there's anti-CCP with 95% specific for rheumatoid arthritis, particularly it is if it is associated with a positive RA as well. Anti-dsDNA, as you know, very much diagnostic of SLE. ANA is a pan markers. They are positive for several different kind of autoimmune diseases. So like this ANCA, which is actually the anti-nuclear cytoplasmic antibody, which also may be diagnostic marker of few of the cases. I am coming later on. Similarly, the anti-thyroid and anti-TG are also the candidates of which can lead to a definite diagnosis. So I will be highlighting on those who particularly lead to a definite diagnosis, not among the other biochemical markers like CRP, like ESR and all other things which actually just contributory and can happen with any of the autoimmune diseases. So I am concentrating my talk on those cases which actually from a department of biochemistry or immunology I can give a definite diagnosis. So now you see, find this common autoimmune diseases you can find in your day-to-day practice: multiple sclerosis, type 1 DM, celiac disease, and all. So I'm coming later one by one, so I'm not describing all. So these are more or less these 18 common areas where we can find the autoimmune diseases, particularly in our community. Now, if I go with the organ-specific autoimmune disorders, first I talk about myasthenia gravis. As you know, is a neuromuscular disorder, is a weakness, starts with the drooping of the eyelids and then covers whole body. And the particular thing is the acetylcholine receptor antibody. The antibody which is here is a blocking kind of antibody. The antibody to acetylcholine receptor, that particular antibody blocks the acetylcholine receptor, and therefore the neuromuscular function is grossly deranged of those patients, and that is the key diagnostic marker of it. So most common gold standard diagnosis of it is by RIPA. There is radioimmunoprecipitation assay, which is the gold standard, which uses iodine 125 alpha bangarotoxin, that is a conjugate which is used for its diagnosis. Nowadays also we use ELISA and FIPA also, but more or less this RIPA is the gold standard for the diagnosis of this receptor. Now when I am talking about thyroid, there are two kinds of autoimmune diseases we encounter commonly in thyroid. One is Hashimoto's thyroiditis and one is a Graves' disease. So first, if I talk about Hashimoto's thyroiditis, it's an inflammation of the thyroid gland which is caused by our own antibody. So maybe produced by some viral infections or some other inducers, but the antibody destroys the thyroid cells. So here you will get an antibody association with two particular antigens. One is TPO, thyroid peroxidase, which is the principal antigen of particularly, I think, rate-limiting step enzyme. So acting on it destroys the thyroid production capacity, and anti-TG destruction of the glands also enhanced by anti-TG. So you will find more than 90% association of this anti-TPO and anti-TG with Hashimoto's thyroiditis, and some cases with Graves' disease as well. But Graves' disease is a bit different type of thing. Hashimoto's thyroiditis is just after destruction of the thyroid glands, there is a definite hypothyroidism prevails. But in Graves' disease, it is difficult. This is another antibody, is a thyroid receptor antibody, but it's a stimulatory antibody. When its antibody is actually when directed against the thyroid receptor, actually stimulates the hormone production. So that leads to a gross hyperthyroid state. Sometimes this antibody has a switching role. Sometimes it may act as a blocking agent also. But mostly it's a stimulating antibody which actually increases the thyroid production, leads to a hyperthyroid condition. Now another one is a type 1 diabetes mellitus, mostly occurs in babies, children, and as you know, it's a antibody against the islet cells of Langerhans, pancreatic islet cell of Langerhans. So the antibodies detected here are islets and antibodies, and also anti-GAD65, anti-islet antigen 2, and also zinc transporter 8. There are 4 kind of antibodies can be detected with IDDM cases, and mostly with the help of the ICAs, that is anti-GAD65 and IA2, they have a diagnostic and prognostic capacity is a very high. So detecting these 2 antibodies, you can have a not only a diagnosis, but also prognosis how fast the patient can go to decay. So we use ADAPT technology with bridging ELISA for this kind of antibody detection. And what is the advantage? Advantage, you have to understand that initially there is a antigen-antibody reaction which goes on destroying the beta cells. And therefore, at a certain point of time, the inflammation is on, but patient is clinically not diabetic. So the antigen, this has got an advantage that if you have these antigens, you can detect these antibodies, you can predict the formation of IDDM, and in this particular stage of, this is the stage 2. See the stage 1, when the inflammation has started, and yet that antibodies can be detected in the blood, but the patient is clinically not yet diabetic or frank diabetic. So if you start therapy from here, you can save the patient to go to up to the diabetic ketoacidosis and other acute stages. So that is one of the very important finding and important utility of this kind of antibody. Addison's disease, as you know, so there is an antibody developed against 21 hydroxylase. So it's present in 80 to 90% cases of the primary adrenal insufficiency. As you know, with the hormone markers also, we can contribute with these hormones. A person with Addison's disease may have initially, there is a deficiency of the peak cortisol. And gradually it happens that the ACTH, which is actually rises as a counter because the cortisol production goes down. So later on the stage, you can find the high ACTH and also even low baseline cortisol when the disease has progressed to the initial stage. So here also, you can detect it much earlier with the antibody which is directed against 21 hydroxylase enzyme. Now we talk about autoimmune gastrointestinal disorder. There are celiac disease, IBD, and also primary biliary cirrhosis. So celiac disease particularly I talk about, which is actually an autoimmune disorder which induced by gluten's and therefore cause a villus atrophy and all this kind of malnutrition. So the specific antibody we actually help here to diagnose is anti-TTG antibody. And what is the advantage of this? And there's another one is anti-endomysium antibody. But advantage of anti-TTG is that if you can diagnose this early, so you can withdraw the gluten and therefore the patient in the early stage of the disease actually you can restrict formation of antibody in significant amount. So gluten restriction can be induced early if you can diagnose the person with the help of this and detecting the antibody. Now the inflammatory bowel disease or IBD, there are two definite kind of IBDs, you know, Crohn's disease and ulcerative colitis. Sometimes you need to have the invasive technologies like the colonoscopy for a diagnosis and also sometimes histology. Now this invasive technology can be reduced a bit because we have seen that in case of, there are two categories of antibodies we find here. One is ANCA and one is ASCA, that is anti-Saccharomyces cerevisiae antibody. And this most important thing is that ANCA is mostly present in UC and ASCA is mostly present in Crohn's disease. So if you go for the diagnosis, if you have a p-ANCA negative and ASCA positive, your diagnosis is mostly about Crohn's. And if you have a high ANCA and low ASCA, 90% of your diagnosis goes for ulcerative colitis. So with the help of this antibody, you can actually avoid this invasive investigations a bit. Now primary biliary cirrhosis, you get this anti-mitochondrial antibody for its diagnosis. And I'm just have to hurry because the clock is actually, I have 2 more minutes, so thank you for the grace. So now talk about the autoimmune vasculitis, which is an inflammation necrosis of the vessel wall. So the diagnostic challenges is at the broad spectrum. You cannot pinpoint it. It is so systemic, it involves so many things. So therefore, candidate for these antibodies of this systemic vasculitis, in broad sense, you have ANCA, you have cryoglobulins, you have anti-GBM and anti-C1q antibody. Now I am coming in detail. So of ANCA, particularly the C-ANCA and P-ANCA, one is cytoplasmic and perinuclear. So P-ANCA and C-ANCA have been directed against 2 antigens. One is PR3, another is an MPO. And cryoglobulins are particularly who under 37 degrees centigrade stabilizes and, precipitates and stabilizes on rewarming. Anti-GBM, as you see, is mostly seen in good posture syndrome. And it directed against the glomerular as well as the lung capillaries. And anti-CIQ particularly is the diagnosed biomarker of hypocomplementaric arterial vasculitis or HUV. ANCA mostly seen in there too many cases is Wegener granulomatosis, MPA and Krogstad syndrome. For Wegener's, you actually find C-ANCA with PR3. For MPA, you get P-ANCA with MPO, and also in Krogstad, mostly C-ANCA with MPO. And anti-GBM, as you know, is an anti-glomerular basement membrane antibody, which affects the glomerular basement membrane as well as alveolar membrane. So therefore, you may get a glomerulonephritis and a pulmonary hemorrhage combination. So cryoglobulins are actually of 3 categories. I cannot have that much time to go. So, and now there is another endothelial cell antibody or AECA, which is found in Takashua arteritis, giant cell arteritis, etc. And anti-LAM2 you can get in RLV. So now autoimmune hematological disorders you get in ITP, AIJ and pernicious anemia. Just going as an ITP is therefore antibody specific to glycoprotein is GP23A, and if you get a diagnosis of it, you can predict this idiopathic, or now it is called immune thrombocytopenic purpura, which usually gets triggered with some viral infection or some others. Autoimmune hemolytic anemia, as you know, there is Coombs test is definite one for diagnosis, and also you will get a complements. So now this is how the Coombs tests are done. So these are autoantibody which is attached to this RBC. So you have an antibody which is specific for the FC portion of the antibody. So it leads to an agglutination, and so therefore you can detect a direct antiglobulin test. Pernicious anemia, particularly this is on the against the intrinsic factors. So it leads to a vitamin B12 deficiency. Particularly the antibody is done against H plus K plus ATPase. So there mimics a vitamin B12 deficiency. How you distinguish it? Distinguished by the Schilling test. What is that? The radioactive cobalt if added with B12, and you ask you give it to the patient. The patient with the B12 deficiency will be replenished with that and will have the cobalt activity in urinary excretion and biliary excretion everywhere. But those who are intrinsic factor deficient, the vitamin B12 will not be absorbed at all, and therefore it will lead to no intestinal absorption and you will not find it in urine. Now we talk about the systemic. There are systemic autoimmune disorders like SLE, Sjogren's syndrome and rheumatoid arthritis. Multiple sclerosis, Angst-Pond scleroderma. So talk about SLE is particularly you diagnose with this anti-dsDNA, anti-Smith antibody, and also anti-Rho and anti-La. So I'm just giving it in a nutshell. This dsDNA is very specific for SLE, U1-RNP mostly for the mixed connective tissue disorder or MTCD. And these are all the things as it will be discussed later on in detail, so I'm not going. Sjogren's syndrome, as you know, it's a multi-area affection is there. So mostly detected by anti-Zo or anti-La antibodies. Rheumatoid arthritis is predominantly, as already been told, that we have two factors here. One is rheumatoid factor and another one is what is anti-citrulline peptide or anti-CCP in common terms. So you will find that the sensitivity and specificity becomes very high, as much as 86 to 99% if you find both anti-CCP and RA factor positive. And therefore also it is useful with the radiology to detect the inflammation grade and also prognosis of the disease. These are the things. I don't want to drag it further. So multiple sclerosis is a chronic inflammatory disease of the CNS, which actually both autoimmune response of T and B cell mediated response. Mainly it is used the ELISpot assay for the diagnosis, and the diagnosis is against the myelin basic protein or MBP and also oligodendrocyte specific protein. So therefore this is all about that. And Angst-Pond, as you all know, the last slide was said about lot about Angst-Pond. So it has an axial skeleton active affection with associated sacroiliitis, uveitis and other systemic manifestations. So HLA-B27 detection is a very important marker of Angst-Pond nowadays. So scleroderma, as you will find in these cases, the systemic sclerosis is a systemic autoimmune disorder characterized by vasculopathy and fibrosis. So therefore it is may have an ANA, topoisomerase and anti-SCL70 antibody detection, and it can be detected by IF, ELISA or line immunoassay, as I think the later on it will be discussed in detail. So I hope I am on time. So I have done the conclusion now. The conclusion is autoimmune disorders are numerous. Detection modalities are largely invasive. So here our role is significant progress of biometric or biochemical assay strategies and sero and immunological assay technologies, which is gradually becoming non-invasive. So, therefore, reliable detection, monitoring, and disease prognostication can be enhanced with these non-invasive technologies nowadays. And obviously, pain to the patient and pain to the procedure is reduced by more and more non-invasive technologies that is detected nowadays for all these disease diagnosis and prognosis. So thank you. These are my references. And I wish I could have taken 5-10 minutes more, but it's very tough to accommodate all. Thank you. Any questions? I can have it in a debate.
Thank you, Sushrut, for a very concise and erudite summation of a really relevant topic. Questions? Okay, you can take them all during the break. So thank you again.
The participants for the poster, please go to the Velvet Lounge and the judges. Dr. Noreen Kassim, Dr. Rajashri Aich, Dr. Priyadarshini, and Dr. Shujoy Shorkar. The participants for the poster to go to the Velvet Lounge, along with the judges, Dr. Abhik Shorkar, Dr. Shilaj, Dr. Tulika Lipi Ghosh.
So as the last speaker for this session, can we have Dr. Bhumika Kumar, please?
There is a pointer. So thank you all. And so already the past speaker has discussed a lot about, very good, wonderful insight about the autoimmunity, their markers, serological aspect, and different assays. So quickly, with alignment to that presentation, I'm going to discuss about the different markers related to the serological aspect mainly. As he said, we are moving into the direction of the non-invasive technologies. So our company, Euroimmune, are continuously trying to, bring up the new markers, new non-invasive technology, so that the diagnostic and the prognostic technology can be enhanced. So we are covering the rheumatology, the whole parameter and the range for all the specialty, like you can see, rheumatology, hepatology, gastroenterology, endocrinology, neurology, nephrology, and dermatology as well. So first of all, I would like to discuss that we have two patented technology from the Euroimmune. One is the biochip technology and another is the titer plane technology. So when we discuss about the biochip technology, what this technology really help is it is the combination of different substrate into the same reaction field. When I say the same reaction field, I'm talking about the one sample you're applying and we have the different biochip combination. So what brought this technology is the miniaturization of the IFT system. So basically you require a very minimum amount of the sample and the excellent standardization and the multiplex testing has been allowed. So second is the processing part of it, rather than using the conventional technology where you directly apply the sample over to the slide. Here we apply the sample over to the titer plane, which is made up of the polystyrol material. So what this technology basically help out in comparison to the conventional technology, you can see that you will be having the simultaneously start of the reaction because the FITC or the fluorescence method is very, very sensitive. So if you have supposedly the 50 samples in your laboratory, so reaction will already start for some of the samples, and the cross contamination, it will helpful, and the identical condition and evaporation can be thing. These all things I already discussed about the past speaker, what are the rheumatology diseases. So I am going to talk about, this is very important part, that as we all know that there is no lifelong treatment is available. So continuous monitoring is required. So there the laboratory play a very, very crucial role with respect to the serological aspect. As we know that there are some invasive technology which are the gold standard, and there are certain guidelines. On that basis the clinician decide, okay, this person is having this autoimmune or the normal diseases can be possible. So with respect to the recommended protocol, as we all know, for the rheumatology, we have the IFA gold standard and the confirmation. So my whole presentation will be revolving around the IFA as well as the confirmatory tests, what are the available. The last, Dr. Sushrut has discussed about what are the marker. I will also going into the insight, like what are the available diagnostic product with us, and what is the particular importance of that biochips, and as well as the marker over to the blot and ELISAs. So with us, we are doing the ANA over to the 1:100 dilution, and the HEP is the screening, which we call it as a gold standard methodology, along with the primate, which will provide you the additional information that you can discuss with us over to the booth or in the private. So these are the Euroline ANA confirmation technology. If you talk about, we have the different blot available. As you talk about the universal blot, so when we say the universal blot, so we say you can use directly when you find something ANA positive. But if you are going for the particular kind of pattern you are seeing over to the nuclear or to the cytoplasm, you can use this entire two blot, and together you can find out which are the different this thing. Apart from that, we have the different disease-specific profile as well. Like here it is mentioned myopathies, systemic sclerosis, and the liver disease also. Particularly, I would like to highlight about the myositis. We have the comprehensive panel for the myositis. So IFT Mosaic gold standard for ANA diagnostic. Euroline, which can cover up to 20 myositis, different autoantibodies can be seen. And very importantly, I would like to highlight and draw your attention over to this marker, which are very much common these days, and people are asking about CN1AC autoantibodies, which are the only marker for the serological diagnosis of inclusion body myositis. So these are the different panels we have in the form of 11 antigen, 15 antigen, 16 antigen, 17 along with the SIN. And in the couple of months, we are going to launch about this, which contain these 3 extra. As I said, these are the number of different 20 antigen you can scan. So as already doctor has discussed about the Crithidea lucile over to the IFA for the dsDNA, I would also say we have earlier the conventional dsDNA ELISA method, which have a sensitivity around 50%. Everybody know about how crucial it is to be having the dsDNA sensitivity over to the blots and other methodology. So we are bringing up this technology where the sensitivity of the system has been increased to 67%. So next parameter which we are going to discuss is the nephrology, ANCA-associated vasculitis and the primary membranous nephropathy. ANCA, we say, still the people are using into the parallel technology. Both are using, as the guidelines suggest. Something has been covered by the IFA, something has been covered by the ELISA to bring the overall sensitivity of the system. We have the 3 biochip combination, ethanol fixed granulocyte, formalin fixed, and everything has their own role, which can be discussed in detail later. And these are the different test systems for the ELISA, monospecific as well as the profile ELISA. This system has increased PR, 3HNHR is almost like 97% of sensitivity. ANCA profile ELISA, where you can detect direct and indirect PNCA, CNCA, and DNA NCA all together over to the single. This is the blot available. GBM, these are the different assay, IFT, monospecific, and ANCA profile. Membranous nephropathy, as people have talked about PLAR. So I would like to say people are talking about this PLAR, which is a very good marker and very important marker with the greater prevalence 70 to 80. And next is the thrombosponding, and then into the picture, which is available for the research purposes. So what we have for this PLAR, which is a non-invasive technology, according to a KITCO guideline, you can avoid the invasive procedure. We have over to the IIFT. If your laboratory have the less number of samples, so that you can go for the IFA. Otherwise, you have a very good lot from the renal department, then you can go for the ELISA. So these, as I would like to highlight, it is a non-invasive method, and you can screen up to the, according to the treatment, relapse you can count, and also you can screen, measure the reoccurrence of the transplantation part of it. With respect to the autoimmune liver, these are the 2 important ones. These are the different autoantibody. You know that this is associated with the PBC, this is associated with the AIH. So we have this 4 biochip combination and the 6 biochip combination, where you can screen up to, if you screen this, you can screen up to 6 antibody. If you take this, you have screen up to 9 antibody. As I would like to highlight, asthma is not, see, we can screen asthma, but anti-affectin is the actual marker for the autoimmune hepatitis, and up to the screening guideline, you have to have this certain kind of score, which is predictive of the autoimmune hepatitis. So these are the different blots available with us. This is going to become in which we are going to highlight the affectin. So till now, people are using IFA for the anti-affecting, and ELISA do not have any pattern. SLALP do not have any pattern. For that, ELISA is required. So people usually doing into the combination of IFA along with the blot or the ELISA, confirmatory test. Last is the neurological diseases. So we have the paraneoplastic. Everybody know about encephalopathies, myasthenia syndrome, stiff person syndrome, demyelinating diseases, and the autoimmune neuropathies. So what is available for these diseases? If I talk about the paraneoplastic, so overall into the neurology system, if I talk about, we have mainly these three assays. If I talk about, one is the tissue-based assay, second is the Euroline, third is the cell-based. Cell-based is nothing but the transfected cell where the people have expressed the particular antigen into it. Like if you want NMDR, they have expressed NMDR and caught it. If it come, it will be positive, otherwise negative. For the paraneoplastic, we have coated the cerebellum and the primate intestine, and you can use the starting dilution 1:10, and if you are using the CSF, you can use NEAT. So usually for the PNS, the guidelines are as such that you use it together. Like immunoblot, we have the immunoblot, you use this together for the better sensitivity and the better result predictability. So these are the different blots. Usually I have seen in the majority of the laboratory, people use these two. These are the 12 antigen and these are the 6 antigen. If supposedly amphiphysine have comes, you can use this. You need not to waste the costlier blot. So this is the thing. For encephalitis, the guideline is for the cell-based assay. As I already said, that are the transfected cell. So these are the different autoantibody, which you all people are very much aware, I must. So these are the panel, as I already mentioned about the biochip technology, the importance. Can you imagine we have quoted a 6-7 antigen over here. Otherwise, you have to order 8 different kit for a particular sample, and you extract the sample also for that particular patient. So this is a beauty, I would like to say, having the biochip in a single patient reaction field. So that's a wonderful part. So serum and CSF both can be used. So detail can be discussed. And lastly, the demyelinating, last speaker also discussed about this disease. I'll just take 2 minutes more. So demyelinating disease, we have into the combination, when you wanted to, segregate for the multiple sclerosis with this kind of disease, because there is an overlapping of pattern. For particularly demyelinating diseases, we have this marker, aquaporin and MOG. So it has been seen that where the aquaporin is present in 40% of the cases, MOG will be there. So we would usually suggest, the guidelines suggest that you should do in the combination. So this is the diagnostic algorithm. For the PNS, you can go for the tissue-based assay along with the immunoblot. For AIA, there is a tissue-based assay, but the pattern are very confusing. That's why guideline I directly go for the CBA, like that is cell-based assay, and for NMOSD, demyelinating cell-based assays. So as I already, the last speaker has discussed about the acetylcholine receptor for the myasthenia gravis. So you can see we have the ELISA for that. And lastly, the ganglioside profile for the peripheral neuropathies. And these are the different automation available with us. These two products are the indigenously made, and this is the headquarter at the Chennai, and these all products, the detail can be discussed from the Euroimmune part of automation. Lastly, I would like to highlight that we are running a very good training program from the past more than 12 years. The name of brand name Sachika. Many of the people from here, I also know that, has come down to Chennai and learned this. So these training program has been segregated into the basic and the advanced session. When we say basic, so we provide the training for ANA and NCA for the 3 day. Basically, it's a 2.5 days. So if I talk about, you only have to do the registration, and the facility for the living has been provided. Travel expenses you have to bear. And this advanced, we are going to discuss about the neuro, dermatology, and the neurology into the details. So we have trained in the past 12 and 13, more than 1,000 doctors has been trained so far. Thank you for your patiently listening, and Capcom for providing this platform to me. Thank you.
That was a nice talk. Please wait.
Any question?
Thank you, Dr. Bhumika. So that concludes our session 1. We'll just take a moment after this to felicitate our distinguished chairpersons, and then we shall move on straight away to our session 2. So CapCon 2024 is in full swing. The seats are filled up. Let's straight go away to session 2. Please feel free to bring your tea and coffee from the counter and have it in your seats. We shall not go for a tea break.